everybody, welcome to Dr. Ghost YouTube channel. Prepping PG entrance one topic at a time. Please like, share and subscribe. Hope you enjoy.
Now we'll talk about, since we know that remnants or the chylomicron remnants, the VLDL, the LDL and the SDL lipoproteins will be finally, once they do their job, they will be finally taken up by the liver and they will be reprocessed into a new lipoprotein, or they will be secreted into the bile. Okay, so how do liver uptake these lipoproteins? Okay, what happens is there are certain receptors on liver which help in the uptake of these lipoproteins. So we will study about ligands on the lipoprotein for uptake by the liver. So the ligands which are present on the lipoprotein for uptake for the liver, the first ligand we'll talk about is ApoE, which is present on remnants. I told you the chylomicron remnant, the chylomicron, after giving the triglyceride to peripheral tissues, it forms chylomicron remnant and acquires ApoE from the blood. Now this ApoE helps in the uptake of the chylomicron remnant into the liver. Now it will be broken down into its various parts like protein, the phospholipids, and the amino acids and glycerol plus fatty acids, and it will be secreted in bile or it will be reused to form the lipoprotein. The next lipoprotein, that is LDL, it contains its receptor on the liver, which is LDL receptor. There will be receptor mediated endocytosis, that is the receptor along with the LDL lipoprotein with the help of ApoB100, which is the main one, and ApoE. There will be intake into the hepatocytes. Along with the receptor, the LDL lipoprotein will be taken into the hepatocyte. This is known as receptor mediated endocytosis. This will be helped by the ligand ApoB100 present on the LDL. The next one called HDL. Now the HDL will also be uptaken by the liver with the help of ApoA ligand. We know that the mnemonic ACE, ApoA, ApoB, ApoC, ApoE will be present on HDL. It will be taken with the help of ApoA. Okay. Now we'll talk about another important concept, which is how HDL does its job. Like from the peripheral tissues, the cholesterol which is present will be taken up by the reversed cholesterol transport. Okay, the HDL will do reverse cholesterol transport from the peripheral tissues. Now the HDL will contain cholesterol. This cholesterol cannot be transported by HDL. It has to be converted into cholesterol ester, which is a neutral lipid, to be transported by the HDL. Okay, I told you in one topic that HDL contains cholesterol ester, which is a neutral lipid. This is an important step in the transport of cholesterol from peripheral tissues to the liver, and this is mediated by an enzyme. Is an important step in the transport of cholesterol from peripheral tissues to the liver, and the cholesterol in the HDL is converted to cholesterol ester with the help of an enzyme LCAT, which is known as lecithin cholesterol acyl transferase. We can decode it from the name itself. Lecithin means phospholipids, cholesterol means cholesterol, acyl means fatty acid transferase, means there will be transfer of fatty acids from lecithin to cholesterol, forming cholesterol ester, which will be uptaken by the liver. Okay, this is how reverse cholesterol transport is achieved, and the enzyme LCAT is very important. You have to know this for exam. Okay, how cholesterol is converted to cholesterol ester in reverse cholesterol transport. Okay, now we'll talk about another important part from this chapter, which will be hyperlipoproteinemias, asked every year in NEET PG and INI. Okay, so the hyperlipoproteinemias, we will have the Frederickson's classification of hyperlipoproteinemia. Okay, in which we will study some types. All the types are not important from exam point of view. The type 1 is due to lipoprotein lipase deficiency or ApoC2 defect. What happens is that I told you the chylomicrons unload the triglyceride to the peripheral tissues. This is mediated by the help of an enzyme present in the capillaries, lipoprotein lipase, and the cofactor or coenzyme of lipoprotein lipase is ApoC2. So when the lipoprotein lipase will be defective, or the ApoC2 defect will be there, the chylomicrons will be unable to load the triglycerides into the peripheral tissues. So the chylomicrons will be elevated more than the VLDL in this conditions, because VLDL also transports the triglyceride to the peripheral tissue. So VLDL will also have problem due to lipoprotein lipase or ApoC2 defect, but the chylomicron will be elevated more than the VLDL. The triglyceride level will be high in the blood because it cannot be transported to the peripheral tissues, and the cholesterol will be normal because the VLDL and chylomicron are not concerned with the cholesterol. They do not contain much cholesterol. There is only negligible amount, and they are not involved in the transport of cholesterol. Now this disease, hence it is known as familial hyperchylomicronemia, because there will be increased chylomicrons in the blood, leading to increase in the triglyceride levels in the blood. So this is known as familial hyperchylomicronemia. Okay, and the next one is type 2A, hyperlipoproteinemia type 2A. Here the defect is in the LDL receptor or ApoB100. I told you, right, the LDL is uptaken by the liver with the help of ApoB100 ligand and LDL receptor. What happens here is the LDL receptor or ApoB100 is defective, so that LDL cannot be uptaken by the liver. So there will be increased LDL lipoprotein in the blood, and the triglyceride level will be normal because LDL is concerned with cholesterol transport, and so the cholesterol level in the blood will be and this is known as familial hypercholesterolemia. Okay, so this is type 2. familial hypercholesterolemia type 2A. Now type 2B is due to an unknown defect. We do not know the defect. Here there will be rise in both the VLDL and LDL in the blood. So because of VLDL the triglyceride will rise, and because of LDL the cholesterol will rise. Both the triglyceride and cholesterol will be high in the blood, and this is known as familial combined hyperlipoproteinemia. Okay, combined hyperlipoproteinemia. Now the last type will be type 3. Type 3 is due to ApoE deficiency. If we reverse the 3, it will look like E only. So this is how you can remember. This is due to ApoE defect. Now ApoE was present in the remnants. So what will be rise in blood will be chylomicron remnants and VLDL remnants. The remnants will rise because ApoE is defective and the remnants cannot be taken up by the liver. So what happens is, since the remnants have increased in the blood, what remnants contain both the triglyceride and the cholesterol. Yeah, okay. Now since the remnants were containing both the triglyceride and the cholesterol, both the triglyceride and the cholesterol will rise. Okay. Now the name of this one is known as broad beta disease. I told you the VLDL remnant or IDL is also known as broad beta lipoprotein. On the basis of that only, broad beta disease, it has been named as broad beta disease. It is also known as bis beta lipoproteinemia. These are beta lipoproteins and hence dis beta lipoproteinemia. Okay. This is all about hyperlipoproteinemias, and very important topic in exam. Asked this year also, one of the types was asked, like type 2A was asked in the NEET PG 2025. Okay, just go through it. Now we'll talk about the clinical features. We have learned how the defect occurs and what will be elevated in blood and what are its different names of different hyperlipoproteinemias. Now we'll learn about the clinical features of hyperlipoproteinemias. What happens? There will be deposition of cholesterol or triglyceride in the tissues, and this will cause the clinical features which is important for solving the questions. Like if the question mentions tendon xanthoma is mainly because of rise in cholesterol. Okay. So the cholesterol will rise, there will be tendon xanthoma. So if the question mentions there is a rise in cholesterol, there is a tendon xanthoma in a person, we can think of a disease which has a high cholesterol like 2A, 2B and 3. Okay, it cannot be type 1 because there will be no high cholesterol in type 1 and there will be no tendon xanthoma there after. So if the question mentions the patient has eruptive xanthomas, okay, eruptive xanthomas is due to elevated triglyceride levels. So if we can find on the basis of that whichever hyperlipoproteinemia has elevated triglyceride level, that can be the answer in the question. Okay, if the question mentions eruptive xanthoma, we can xanthomas and xanthomas are confusing, so we can remember with the help of mnemonic. T is not for T, that is tendon xanthoma starting from T will not be present in triglyceride. Okay, it will be present in cholesterol. Okay, now if the question mentions Palmer and tuberoeruptive xanthoma, it is due to increase in the remnants, that is VLDL remnant and VLDL and chylomicron remnant. That will be type 3. Mainly in type 3 there will be Palmer and tuberoeruptive xanthomas. Now if the question says milky plasma, it is due to chylomicrons elevation. Okay, what happens? Chylomicrons elevated, there will be elevated triglyceride, the plasma will become milky and hence it is known as milky plasma. It will be mainly in type 1, which is a familial hyperchylomicronemia. Okay, now if the question mentions acute pain in the abdomen, okay, acute pain in the abdomen is due to elevated triglyceride levels. What happens is when the triglyceride level elevate, there will be blockage of blood vessels supplying the pancreas, and this will cause necrosis of the pancreas, causing acute pancreatitis. And if the question mentions there is acute pain in the abdomen, it will be a disorder or the hyperlipoproteinemia, which is mainly concerned with triglyceride levels increase. You can get the clue in questions what are they talking about. Now the next disorder we are going to talk about is A beta lipoproteinemia. We can divide this word into A which means absent, okay, and beta lipoproteins. We know what are the beta lipoproteins, okay. LDL, VLDL and VLDL remnants are known as beta lipoprotein. So VLDL, IDL and LDL will be elevated. Cut here, okay. So what happens is there will be absent VLDL, IDL and LDL, which are the beta lipoproteins. A means absent and beta lipoproteins will be absent, which contains ApoB48 or ApoB100, okay. Now this is due to mutation in a protein called MTTP, microsomal triglyceride transport protein. Okay, so what happens is MTTP transports triglyceride from intestine and liver to chylomicrons and VLDL. So what happens is this MTTP, microsomal triglyceride transport protein, will transport triglyceride from intestine and liver to the chylomicrons and VLDL. Since there is mutation in this protein, the triglyceride will be not transported into the chylomicrons and VLDL, and hence there will be deficiency of VLDL, IDL and LDL. Okay. So there will be decreased plasma triglyceride levels, which will be not absorbed from the intestine because of mutation in MTTP. And since the triglycerides are not absorbed, means the fat is not absorbed, their fat soluble vitamin absorption is also affected. We have the fat soluble vitamins A, D, E, K. Okay, so what will be the clinical features? Since vitamin E will be deficient due to non-absorption of vitamin E because of decreased triglyceride absorption, there will be neurological deficit. Vitamin E is required for brain development, and since it's deficient, there will be neurological deficit. There will be failure to thrive, and there will be diarrhea. Like vitamin A is essential for maintaining the mucosal lines. It will be deficient, there will be diarrhea. Okay, there will be a hematologic manifestation, which is very important. Okay, we have to remember this hematologic manifestation, which is acanthocytosis. There will be speculated RBCs, and this will cause anemia and breakdown of the acanthocytes, and there will be hyperbilirubinemia. So you have to remember acanthocytosis. The question will most of the times will mention acanthocytosis, or they will ask about acanthocytosis. So A beta lipoproteinemia is due to the mutation in MTTP, which will cause deficiency of fat soluble vitamins, and thereby the manifestations. An important hematological manifestation in A beta lipoproteinemia will be acanthocytosis, which will be speculated RBCs. Okay, that's all about this topic. This is a vast topic, but it is frequently tested in all the exams.